thank you so much for the invitation. And I do have a disclaimer as a first presenter. If you see someone jumping out in the pool in his bathing suit after this presentation, it's not me. However much Dwight from Ohio State tries to convince you otherwise. So, this is
They
the
have a Michigan Ohio State thing going here, clearly.
So this is a very small hypothesis generating study that I kind of cooked up with my mentor, Dr. Gadgil, back in Kermanos. And just to give you a background, so a third of all non-small cell lung cancers are stage 3 at diagnosis, and a quarter of these would achieve long-term survival. The usual treatment is combined mortality, and that includes chemoradiation, surgery followed by chemoradiation, or just surgery followed by chemotherapy. So this is the standard NCCN guideline right now. So after you treat them, you do end up doing surveillance scans every 6 to 12 months in the first 2 years, and after that, it's annual CT scans. So the question was simple: which is superior? Is it actually the surveillance scans that help, or can we have a strategy where we can just do scans when there's some symptom-directed approach? And we conducted this small retrospective analysis of all these stage 3 lung cancer patients at our center to see how many were detected on surveillance scans. So this was a single institution retrospective review which utilized Carmonas Cancer Center lung cancer database. It's a HERIC database that was started in 2010, which is funded by a private family over there. And the primary objective was to estimate the percentage of patients who had documented tumor recurrence on surveillance scan. Inclusion criteria were pretty simple. All stage 3 lung cancer patient who had been treated in the correct fashion by the definitive therapy between 2011 to 2013 were included. And we had certain exclusion criteria, but to sum it up, anybody who had inadequate documentation and was not eligible for based on treatment, if they deviated from the treatment, we just excluded them out. And uh, pretty simply, these are the results. 54 patients met the eligibility criteria during this time. The mean age was 61 years. Interestingly, 66% were females and 34% males. Now, mind you, ours is more of a African American dominated population, but still we had almost equal number of African Americans and Caucasians in the data mix, and around 85% were current and former smokers. Now, histology wasn't surprising at all. 67% were adenocarcinoma, 31% squamous cell, and rest 2% were other histologies. So this is the breakdown based on treatment received. Uh, Mostly were, of course, chemoradiation therapy, 69%. 22% did get surgery with chemoradiation, and a very small number were the ones who got surgery followed by chemotherapy. So we did have a median follow-up of around 18 months in this patient population, which I thought was pretty reasonable. And in all, from the 54, we saw 18 patients who had disease recurrence, and interestingly, 11 of them had recurrence within the first year. So uh, now this is the actual result of these 18 patients. 17 were detected on surveillance scan, and only one symptom directed. I mean, the patient presented with shortness of breath to the hospital, and that's how he was diagnosed. We did run some stats, but I didn't include it over here because it doesn't really make a difference. So here are my conclusions from this study. So in this retrospective analysis in stage 3 non-small cell lung cancer who had completed definitive therapy, all the recurrences were detected on surveillance scan with just one being symptom-directed approach. And this strongly suggests that routine surveillance scan do provide a clinical utility. Now, I do agree this small analysis is marred by problems, including being a small study, retrospective, single institute. But all in all, I think it was a hypothesis-generating study for me and a good start. And I do plan to work with my mentor to kind of expand it to a bigger population. With this, I've finished. Thank you. And if you have any questions, I'm happy to take them.
So I take it these were all CT scans, or were they PET CT scans?
No, CT scans.
CT
Yeah.
scans. And of the 18 recurrences, how many of them were recurrences within the treatment field versus recurrences outside the treatment?
I, don't have that clear data, but I think around 50% were one that had within the treatment field. And
Because those are the harder ones to detect even on a CT scan.
yeah, agree.
Then while John comes up, isn't the big question whether picking up these recurrences early translates into improvements in survival?
Yeah,
Because if you're not making patients live longer by doing these frequent CT scans,
yeah,
what difference does it
yeah.
make?
So then they go into the to a different realm altogether. Then they probably go into the more advanced realm and advanced treatment regimen. So probably cure at that time would be questionable, depending upon how the disease recurs.
And then was there, could you get any hint of the time frame? So, again, where if this is the times where you should be doing these kind of scannings to
Yeah.
find it.
So one thing I have to admit it is there we do like scans every 4 to 6 months instead of following the 6 to 12 months, and most of the recurrences were within the first year, and almost all were like within the first 8 to 9 months. So I think the earlier time frame of 6 months is probably reasonable right now. Any other questions?
Other questions from the audience? Do you have a sense for how many of these recurrences occurred in the brain?
I don't think anybody recorded in the brain from this data. Yeah, interestingly.
Because the existing literature would point out that nearly 30 to 40% of the patients will recur in the
You're
brain
right.
after stage 3 treatment.
Yeah, they did not, and I think a bigger data set that I'm probably planning to look at is what probably will answer that question too.
Because then the question comes, if that's a significant number, should you also be getting MRIs or some sort of a brain imaging procedure longitudinally?
Yeah, I think right now it's more the symptomatic approach to the brain itself, unless they're florid stage 4, then probably, but right now, at least for stage 3, we don't usually do brain scans, and I don't think we did much on these people anyways.
And if you plan to take this further, I would say you should include even surgically resected stage 1, 2 patients, because we don't have any guidance even for those patients as to how we surveil.
Yeah.
You may be able to get a bigger data set.
I think that's a good idea. Yeah, I think that's a good idea. Thanks for that.
Any other questions? Thank you very much.
Thank you.